Once again with a new topic on the menopause and HRT. So this is on the demand of the girls who are appearing in the exam that menopause is very difficult for them and they must know okay, how we give the hormone replacement therapy. So the learning objectives, definition and the terminology used in the menopause, the pathophysiology, symptoms and signs, long-term risk of estrogen deprivation, the management of the menopausal symptoms, and hormone replacement therapy. This is totally taken from NICE guideline 2019. Menopause is a biological stage in a woman's life that occurs when she stops menstruating and reaches at the end of the natural reproductive life. So this is the biological stage जो सबको आनी है. एक खास पीरियड पे यूजुअली एट द एज ऑफ द 51 ईयर्स हर औरत इस पीरियड से गुजरेगी. जैसे बोलते हैं ना कि हर जी रूह को मौत का मज़ा चखना है, मौत का जायका चखना है. हर औरत को इस एक ख़ास मुद्दत पे मीनोपाज आएगा. This is the biological stage. It's defined when a woman has not had a period for 12 consecutive months for a woman reaching menopause naturally. So जिसको 12 महीने consecutive periods नहीं आए, its label is menopause. So perimenopause, there are different stages. The perimenopause or menopause transition or climactic. These are the terminology which are used when this is the time period from when the ovaries start to fail, and symptoms such as irregular periods or hot flushes may begin. It's until 12 months after the last menstrual periods. So ये एक स्टेज है जब ओवरीज अपना काम करना बंद करना स्टार्ट करती हैं. जब ओवरीज अपना काम बंद करना स्टार्ट करेंगी तो आहिस्ता आहिस्ता सिम्टम्स भी शुरू हो जाएंगे. एंड दीज सिम्टम्स आर द इरेगुलर पीरियड्स और हॉट फ्लैशेस. और पोस्ट मेनोपॉज इज द टाइम आफ्टर द कंप्लीट सीजेशन ऑफ मेंस्ट्रुएशन आफ्टर 12 months of amenorrhea. Premature menopause or premature ovarian insufficiency. Menopause that occurs before the age of the 40 years. It can occur naturally or as a result of medical or surgical treatment. This is called a premature menopause. The late menopause, when menopause occur at the age of 55 years. जिसको 40 साल से पहले menopause start हो जाए, that is called the premature menopause or premature ovarian failure. और जिसको 55 साल के बाद तक stop हो, that is called the late menopause, because the average age is 51 to 52 years. ये 45 साल के बाद 55 साल तक इस ड्यूरेशन में किसी भी वक्त हो सकता है. Why this menopause is important? Because the woman lives many years after their ovaries stop producing estrogen, and the lack of estrogen can have significant short and long-term effects. So the aim is to provide advice for healthcare professionals and women regarding the menopause and the way symptom relief can be achieved. So that's why it's very important. What's the physiology? The pathophysiology, the changes associated with menopause occurs when the ovaries stop maturing eggs and secreting estrogen and progesterone. जब ओवरीज अपना काम करना बंद कर देंगी, एस्ट्रोजन एग नहीं बनेगा, तो एस्ट्रोजन और प्रोजेस्टेरॉन भी रिलीज नहीं होंगे, क्योंकि फॉलिकुलर सेल्स और थीका सेल्स दे आर रिस्पॉन्सिबल फॉर द सिक्रीशन ऑफ द एस्ट्रोजन एंड द प्रोजेस्टेरॉन. जब फॉलिकल ही नहीं बनेगा तो एस्ट्रोजन और प्रोजेस्टेरॉन सिक्रीट नहीं होंगे. सो देयर इज नो नेगेटिव फीडबैक टू द पिट्यूटरी, एंड पिट्यूटरी इज कंटिन्यू रिलीजिंग द एफएसएच एंड एलएच, सो देयर लेवल इज हाई. वंस द ओवेरियन गैमेटोजेनिक फेल्यूर स्टार्ट हो जाएगा, जब ये फेल्यूर स्टार्ट हो जाता है तो 2 पॉइंट्स आती हैं. या तो फेल्यूर इन द क्वालिटी अच्छी नहीं है, नहीं बन रही है. एम्ब्रियोनिक क्रोमोसोमल एनोमलीज लाइक ट्राइसोमीज, increase spontaneous miscarriage. So after the 45 year of age, the ovarian gametogenic failure start होना शुरू हो जाता है, and once there is failure in the quality, it will lead to the chromosomal abnormalities or increase spontaneous miscarriage rate. जब क्वांटिटी कम हो जाएगी तो लॉस ऑफ फॉलिकल, डिक्रीज फर्टिलिटी रेट. जब क्वांटिटी कम हो जाएगी तो फर्टिलिटी रेट कम होगा. जब क्वालिटी कम हो जाएगी तो ट्राइसोमीज और स्पॉन्टेनियस मिसकैरेजेस होंगे. जब ये काम करना बंद कर देंगी तो टोटली इनफर्टाइल और सबफर्टाइल, देयर इज नो प्रेगनेंसी एंड देयर इज deprivation of the estrogen and progesterone. Ovarian hormonal failure, the estrogen deprivations. What are the clinical manifestations resulting from ovarian hormonal failure or estrogen deprivations? These are divided into acute manifestation of the menopause, medium term symptoms, the long term symptoms. क्या होगा जब estrogen body में नहीं होगा या कम हो जाएगा तो क्या होगा? It will lead to the acute manifestation of the menopause, that is changes in the menstrual pattern, menstrual cycle pattern. They may be lengthy, may be shortened to 2 weeks, 2 to 3 weeks, or lengthened to many months. The amount of blood loss may alter and most commonly increases slightly. Hot flushes and night sweats that affect 70 to 80% of the women. They are self-limited, usually resolving without treatment within 1 to 5 years. Mood swings, panic attacks, depression, fatiguefulness, forgetfulness, and difficulty in concentrating, headache. These are the acute manifestation of the menopause. The medium-term symptoms, these are the genitourinary symptoms. Vaginal dryness and lead to the dyspareunia, reduced libido, atrophic urethritis, diminished urethral mucosal seal, loss of compliance, and irritations. These changes predispose to both stress and urge urinary incontinence. So the woman who experiences a menopause, they may suffer from stress or urge incontinence. In addition to that, there is thinning of the skin, hair loss, brittle nails, and generalized aches and pains are associated with reduced estrogen level. The long-term implications, the increased incidence of the osteoporosis, cardiovascular diseases, and stroke. It is unclear whether dementia is associated directly with a fall in the estrogen level or not. Diagnosis, how we diagnose the perimenopause and the menopause. The diagnosis of the perimenopause, that is based on vasomotor symptoms and irregular periods in a woman whose age is over 45 years. Without any laboratory test, you diagnose the perimenopause in a woman whose age is more than 45 years and she has vasomotor symptoms and irregular cycles, irregular menses. The diagnosis of the menopause in the woman whose age is more than 45 years and who do not have a periods for at least 12 months and she is not using any hormonal contraception. It's difficult to diagnose the menopause in the woman who is taking hormonal treatment, like OCPs for treatment of the heavy periods. So the woman who is absent of the periods for at least 12 months, she is not using any hormonal contraception, she is over 45 years, without any laboratory test, you diagnose that she is in the menopause. Do not use the following laboratory and imaging tests to diagnose the peri or menopause in women aged over 45 years. AMH, inhibin A, inhibin B, estradiol, antral follicle count, and ovarian volume. The women who are 45 years do not use these for the diagnosis of perimenopause and the menopause. Consider using FSH test to diagnose the menopause only in a woman whose age is 40 to 45 years having a menopausal symptoms. or having a change in their menstrual cycle. In a woman under 40 years in whom you suspect the menopause, mean premature ovarian insufficiency. If you suspect that if you suspect that she has a menopausal symptoms and she is under 40 years, then you will advise for the serum FSH test. Do not use FSH test to diagnose menopause in women using combined estrogen progesterone contraception or high dose progestogen because they cause the negative feedback on the pituitary. These hormones are high level in the blood and they cause the negative feedback on the pituitary. So do not use these FSH test for a woman who is using these hormones, the OCPs or high dose progesterone, or any problem for HMB, for heavy menstrual bleeding. Once the woman who is approaching the perimenopause or menopause stage and having a symptoms, you will give information and advice regarding an explanation of the stages of the menopause, the common symptoms and diagnosis, lifestyle changes, and interventions that could help journal health and well-being, benefits and risk of treatment for menopausal symptoms, long-term health implication of the menopause. तो ये सारी चीज़ें आपने उनको डिटेल में बतानी है कि स्टेजेस मेनोपाज की क्या स्टेजेस हैं, पेरीमेनोपाज, मेनोपाज, पोस्ट मेनोपाज, लाइफ स्टाइल चेंजेस एंड इंटरवेंशन जो उसकी सेहत के लिए बहुत अच्छी हो, benefits and risk of treatment for the menopausal symptoms like hormone replacement therapy, and the long-term complications of or implications of the menopause. ये चीज़ें ज़रूर बतानी है. Explain to women that they may experience a variety of symptoms. These are variety of symptoms जो मैंने पहले स्लाइड्स में बता दिए थे कि वाजोमोटर सिम्टम्स होंगे, मस्कुलोस्केलेटल सिम्टम्स हैं, इफेक्ट ऑन मूड है, यूरोजेनाइटल सिम्टम्स हैं एंड सेक्सुअल डिफ़िकल्टीज. ये चीज़ें आपने उनको बतानी है. Number third, give information to menopausal women about the types of treatment for the menopausal symptoms. So these are hormonal like hormone replacement therapy, non-hormonal for example clonidine, SSRI, SNRI, non-pharmaceutical for example cognitive behavioral therapy. So you have to give information regarding all these available modalities for treating the symptoms of menopause. Give information about contraception to women who are in the perimenopausal phase. जो औरत पेरीमेनोपाजल फेज में और स्टिल ब्लीड कर रही है, menstrual periods आ रहे हैं उसको, though they are irregular, she may conceive. So उनको continue for the contraception. You have to advise if she is already taking the contraception, वो पहले से ले रही है, तो she should continue it. Offer the women who are likely to go through menopause as a result of medical or surgical treatment, or those women who have a risk for the cancer or having a cancer. You will offer to them the support and information about menopause and the fertility before they have their treatment referral to a healthcare professional with expertise in the menopause. जिन औरतों की स्टेक्टोमी होनी है, ओफरेक्टोमी होनी है, या जिनको कैंसर की वजह से कीमोथेरापी और रेडियोथेरापी देनी है, जहाँ पे आइट्रोजेनिक मेनोपाज होगा, यू हैव टू ऑफर देम, इन्फॉर्म देम कि फर्टिलिटी भी नहीं होगी और पीरियड्स भी नहीं आएंगे. This is because of the gametogenic failure, ovarian failure. So you will support them and give the full information about the menopause and the fertility and refer them to the clinic where expertise for the menopause is available. How we manage the menopause? If the woman who experiences the menopause, how we treat them? So you will counsel and advise regarding the diet and lifestyle advice, particularly the smoking cessation, weight loss, alcohol reduction, and increasing exercise to help journal health and well-being. Available medications, hormone replacement therapy, complementary and non-hormonal alternative therapies, calcium, vitamin D, selective estrogen receptor modulators, and other specific agents for osteoporosis like bisphosphonates. For some women, the menopausal symptoms are mild and of short duration, do not require management beyond lifestyle adjustment, education and reassurance. सबको ट्रीटमेंट की ज़रूरत नहीं पड़ती है. जिनमें माइल्ड और शॉर्ट ड्यूरेशन के लिए सिम्टम्स हो रहे उनमें आप लोग लाइफस्टाइल एडजस्टमेंट का बता दें. एजुकेशन रीएश्योरेंस द वुमन इन द अदर वुमन who have a symptoms distressing symptoms that may require short-term treatment with hormonal replacement therapy. The non-hormonal alternatives may be suitable for women not wishing to take estrogen-based therapy or those who have a contraindication to HRT. उनमें you people advise for the non-hormonal treatment. What is the treatment of short-term menopausal symptoms? The woman who has the vasomotor symptoms. क्या करना है उसको? जिसको डिस्ट्रेस करें, वो नींद में से उठ जाती है, हॉट फ्लैशेस हो रहे हैं, and she's in a sweating all the times. So you will treat her for after discussion with her the short-term benefits mean used for only short-term, long-term benefits and their risk. क्या देना है उसको, क्या ऑफर करना है? ईस्ट्रोजन अलोन टू वुमेन विदाउट अ यूट्रस. जिसकी पहले से हिस्टेक्टोमी हो चुकी है उसको सिर्फ ईस्ट्रोजन प्रिपरेशन देनी है. जिसको यूट्रस है मीन उसकी हिस्टेक्टोमी नहीं हुई है, यू विल गिव ईस्ट्रोजन एंड प्रोजेस्टेरॉन. काउंटर इफेक्ट द एक्शन ऑफ द ईस्ट्रोजन. डू नॉट routinely offer SSRI, SNRI and clonidine is the first line treatment for vasomotor symptoms alone. किसी को भी सिर्फ वाजोमोटर सिम्टम्स हो तो फर्स्ट लाइन ट्रीटमेंट SNRI, SSRI और क्लोनिडिन नहीं देनी. The hormone replacement therapy is the best for vasomotor symptoms and the first line treatment. The woman who has contraindication for HRT, then you have to think about others. Isoflavins or black cohosh may relieve the vasomotor symptoms, but you will explain her the multiple preparations are available and their safety is uncertain. Interaction with other medications have been reported. Psychological symptoms. For psychological symptoms, consider HRT to alleviate low mood that results from menopause. Consider CBT, the cognitive behavioral therapy for low mood or anxiety that result from menopause. There is no clear evidence for SSRI or SNRI to ease the low mood in menopausal women who have not been diagnosed with depressions. So, अगर किसी को menopause डिप्रेशन नहीं है तो SNRI, SSRI नहीं देने. लो मूड की वजह से उसको डिप्रेशन नहीं है पहले से, तो अगर सिर्फ लो मूड है और कोई डिप्रेशन नहीं है तो नहीं देने. लो मूड की वजह से आप उसको CBT दे सकते हैं, HRT दे सकते हैं. Altered sexual function. If hormone replacement therapy alone is not effective for women who have low sexual desire, consider testosterone supplementation. एक वुमन जिसको सेक्सुअल डिज़ायर ही नहीं हो रही है, लॉस ऑफ लिबिडो है, HRT भी ले रही है, कोई फ़ायदा नहीं है उससे भी, कोई बेनिफिट नहीं आ रहा, you have to aid the testosterone supplementations. Urogenital atrophies. Offer vaginal estrogen to women with urogenital atrophy. Though she is taking the systemic HRT, you have to continue the treatment and give the vaginal estrogen creams for as long as you need it to relieve the symptoms. Consider vaginal estrogen in women where the systemic HRT is contraindicated. HRT ले रही है फिर भी उसको देनी है, HRT contraindicated है फिर भी देनी है. Vaginal estrogen does not relieve the symptoms of urogenital atrophy. अगर वो symptoms relieve नहीं हो रहे estrogen से, you consider increase the dose बढ़ा देना है. Explain the woman that symptoms often come back when treatment is stopped. Adverse effects from vaginal estrogen are very rare. They should report unscheduled vaginal bleeding. Advise women with vaginal dryness that moisturizer and lubricant can be used alone or in addition to vaginal estrogen. Do not offer routine monitoring of endometrial thickness during treatment for urogenital atrophy. मैनेजमेंट ऑफ सिम्टम्स आफ्टर ब्रेस्ट कैंसर. सपोज द वुमन, उसको ब्रेस्ट कैंसर हुई थी, अब उसको ट्रीटमेंट चल रही है, टेमोक्सिफेन दे रहे हैं उसको कैसे मैनेज करना है. And she has the menopausal symptoms. The women who have had breast cancer or who are thought to be at risk of breast cancer and who have menopausal symptoms should be offered a discussion about all treatment options. Of the non-hormonal option, St. John words may be used, but it should be noted that it may interact with other medications. The antidepressant fluoxetine and paroxetine, which have been used in the past for vasomotor symptoms, should not be used in women who are taking the tamoxifen because of interaction can occur that will reduce the effectiveness of the tamoxifen. Women who are at risk of breast cancer should receive care from healthcare professionals with expertise in menopausal care. Complementary therapy and unregulated preparations. Explain to women that efficacy and safety of unregulated compounded bioidentical hormones are unknown. अगर कोई बोलता भी है कि हमने ये चीज़ें सुनी है, रेड क्लोवर का सुना है, फाइटोसोया का सुना है, सोया आइसोफ्लेविन का सुना है, you will tell them their safety is unknown. Explain to women who wish to try complementary therapy that the quality, purity, and constituents of products may be unknown. Advise women with a history of or at high risk of breast cancer that although there is some evidence that St. John's words may be of benefit in relief of vasomotor symptoms, there is uncertainty about appropriate doses, persistence of effect, variation in the nature and potency of the preparations, potential serious interaction with other drugs, including tamoxifen, anticoagulants, and anticonvulsant treatment, making their treatment ineffective. Side effects or adverse events. So you would tell them all the problems कि ये चीज़ें हैं, ना सेफ्टी का कुछ पता है, ना उसकी क्वालिटी का कुछ पता है, ना प्योरिटी का कुछ पता है, और उसके अंदर क्या चीज़ें उसका भी नहीं पता. तो ये हम आप लोगों को बता देते हैं. HRT. Now coming to the hormone replacement therapy, उसकी टाइप्स क्या हैं, उसकी रूट्स क्या हैं, उसके डोजेस क्या हैं, side effects, indications, and contraindications. We are going to brief talk on the HRT, not in the detail. The detailed talk on the HRT is the separate lecture. So types: estrogen alone, combined hormone replacement therapy. The routes available: oral and the non-oral, that could be transdermal, transvaginal, gels, IUCDs. So these are the non-oral. Their benefits, they are written here. The transdermal patch, gel, even nasal sprays are available. Topical, intrauterine system, the Mirena. Indications for non-oral route. This is a patient preference कि मैं oral नहीं खाऊंगी. Poor symptoms control with oral treatment. Side effects, nausea with oral treatment. History of migraine. Risk of strokes, venous thromboembolism, hypertriglycemia, current hepatic enzyme inducing agents like anticonvulsant therapy, history of gallstones, bowel disorders that may affect absorption of oral therapy, and lactose sensitivity because जो tablets हैं they contain the lactose. The benefits of the HRT: relieving of the vasomotor symptoms, improvement noted within 4 weeks. For all women, the lowest effective dose should be used for the shortest time. Mood or sleep disturbance, improve in the sleep by elevating the night sweats. It's not known whether HRT has a direct effect on the mood, irritability, or anxiety, or whether these effects are due solely to the elevation of hot flashes and sleep disturbance. ये symptoms hot flashes की वजह से हो रहे, night sweats की वजह से हो रहे. HRT should not be used as a monotherapy for depression. HRT is most likely to be useful if there are other menopausal symptoms. Urogenital atrophy well responds with the HRT, the systemic HRT, estrogen creams. Symptoms can occur on cessation of the therapy. Dementia. Explain to menopausal women that the likelihood of HRT affecting their risk of dementia is unknown. Loss of muscle mass and strength. There is limited evidence suggesting that HRT may improve the muscle mass and strength. Muscle mass and strength is maintained through and is important for activities of daily living. Osteoporosis. HRT reduces the risk of spine and hip as well as other osteoporotic fractures. Currently, HRT is currently not recommended as a first-line treatment for osteoporosis prevention. While alternatives to HRT use are available for the prevention and treatment of osteoporosis in elderly women, estrogen may still remain the best option, particularly in younger and or symptomatic women. It is cheaper than other alternatives such as bisphosphonates. यंग वुमेन में एस्ट्रोजन आप दो, जहाँ पे सिम्टम्स हैं वहाँ पे दो, मगर प्रिवेंशन की वजह से एल्डरली वुमेन में इट्स नॉट फर्स्ट लाइन थेरेपी. कोलोरेक्टल कैंसर. HRT reduces the risk of colorectal cancer by about one third. There is no information about HRT in high risk population, and current data do not allow prevention as a recommendation. Cardiovascular diseases. The HRT does not increase cardiovascular disease risk when started. Cardiovascular disease risk when started in women under 60 years. Does not affect the risk of dying from cardiovascular disease. These are the MCQ questions. It does not reduce the cardiovascular disease risk when starting in women under 60 years. Does not affect the risk of dying from cardiovascular disease. Be aware that the presence of cardiovascular risk factor is not a contraindication to HRT as long as they are optimally managed. HRT with estrogen alone is associated with a no or reduced risk of coronary heart disease. HRT with estrogen and progesterone is associated with a little or no increase in the risk of coronary heart disease. अलग से दे रहे हो कोई रिस्क नहीं है या बहुत ही कम है. कंबाइन दे रहे हो तो भी रिस्क नहीं बढ़ेगा, टोटली रिस्क नहीं होगा. टोटली रिस्क नहीं है अगर कंबाइन दे रहे हो. अगर एस्ट्रोजन अलोन दे रहे हो तो नो और रिड्यूस्ड रिस्क. स्ट्रोक. Explain to women taking oral but not transdermal estrogen is associated with a small increase in the risk of stroke. Oral preparation से small increase in the risk of stroke. Transdermal से नहीं होगा. So explain that the baseline population risk of stroke in women under 60 years is very low. जो 60 साल से कम है उनमें तो बहुत ही कम रिस्क है. Type 2 diabetes. Taking HRT either orally or transdermally is not associated with increased risk of developing type 2 diabetes. HRT is not generally associated with adverse effect on blood glucose control. Consider HRT for menopausal symptoms in women with type 2 diabetes after taking comorbidities into account and seeking specialist advice if HRT is needed. What are the risks? Risk of breast cancer. Explain the woman. The baseline risk of breast cancer for women around menopausal age varies from one woman to another. ये नहीं है कि सबको वही रिस्क होगा. It varies from one woman to another according to the presence of underlying risk factors. Estrogen alone is associated with a little or no change in the risk of breast cancer. HRT with estrogen and progesterone can be associated with an increase in the risk of breast cancer. Any increase in the risk of breast cancer is related to the treatment duration and it reduces after stopping HRT. Venous thromboembolism. Explain to women that the risk of VT is increased by oral HRT. The women who are taking transdermal HRT given at a standard therapeutic dose is no greater than baseline population risk. So in the woman, you consider the transdermal rather than oral for menopausal women who are at increased risk of venous thromboembolism, including the woman whose BMI is more than 30. Those with a strong family history of VTE or an hereditary thrombophilia to a hematologist for assessment before considering HRT. Endometrial cancer. Risk is not completely eliminated with monthly sequential progestogen, especially when continue for more than 5 years and also with long cycle HRT. No increased risk of endometrial cancer has been found with continuous combined regime. If you are giving the continuous combined regime estrogen and progesterone, no risk. Tibolone has also been reported to increase the risk of endometrial cancer. Unopposed estrogen therapy increases the risk of endometrial cancer in women with uterus. Adding a progestogen to estrogen therapy combined HRT for at least 12 days per month greatly reduces this risk. But ये जो 12 days आप दे रहे हो ये completely reduce नहीं करेगा. It's not completely eliminated. कंटिन्यूस दे तब रिड्यूस रिस्क होगा जब कंटिन्यूस कंबाइंड HRT दे रहे हैं. Gallbladder disease, HRT increases the risk of gallbladder disease. The risk might be lower with transdermal page. Gallbladder disease increases with aging and with obesity. HRT consultations. The decision to use the HRT should be discussed with each woman on an individual basis, taking into consideration her history, the risk factors, and the personal preference. So prior to starting the HRT, the assessment is very necessary. You have to assess the menopausal state and the symptoms, the stage of the menopause, whether she is in the perimenopause or in the postmenopause, time of the last menstrual period, bleeding pattern, presence or absence of acute menopausal symptoms, using of contraception, whether she is currently using any contraception. Continue contraception for 1 year. If she is using it, advise her to continue contraception for 1 year after the last menstrual period in women over 50-year-old or for 2 years in women under 50-year-old. The woman taking HRT should be use barrier methods in IUCDs or levonorgestrel releasing IUS. Women taking combined OCPs do not need to have HRT added. Contraindications: hormonal dependent malignancy like endometrial cancer, current or past breast cancer. So you have to rule out for the contraindication of the HRT. These are contraindications: hormone dependent malignancies, active or recent arterial thromboembolic disease like angina, MI or stroke, VTE, करंट प्रेगनेंसी में हुआ हो या एक्टिव लिवर और रीनल डिजीज, अनइन्वेस्टिगेटेड वजाइनल ब्लीडिंग, intermittent porphyria. So venous thromboembolism, current pregnancy, active liver or renal diseases. These are the contraindications. So ask about the family history of cardiovascular disease, osteoporosis, venous thromboembolism, breast cancer, bowel cancer, ovarian cancer, hypertension, diabetes, family history of check risk factors for coronary heart disease, family history of premature myocardial infarction or stroke, cigarette smoking, sedentary lifestyle, and the obesity. Check risk factor for osteoporosis. What does the patient want? Does she wants to take HRT? If not, what alternative should be preferred? Discuss healthy lifestyle options to prevent osteoporosis and cardiovascular disease. These are the assessment before starting the HRT. Examination prior to HRT, we check the body mass index and the blood pressure should be recorded. Breast examination and pelvic examination should be carried out if indicated by personal or family history. Otherwise, no need of doing these examination if there is no any history of personal or family history of high risk factors or contraindications. Investigations prior to HRT. No investigation are routinely indicated before starting the HRT. Serial FSH level if premature menopause is suspected. Thrombophilia screening in women with a personal or family history of venous thromboembolism. Endometrial assessment when sudden change in menstrual pattern, intermenstrual bleeding, or a postmenopausal bleach. Mammography if a woman is at high risk of breast cancer. Otherwise, no investigations are routinely indicated before starting HRT. When to start HRT and when to stop? अब HRT आपने दे दी, आपने असेसमेंट कर लिया, आपने सब कुछ कर लिया. अब ये कि स्टार्ट कब करनी है और स्टॉप कब करनी है. HRT can be commenced for vasomotor symptoms or low mood or anxiety that is menopause related. Since we cannot predict how long symptoms will last, there should be no arbitrary limit for duration of use of HRT, and previously held view that HRT should be stopped after 2 to 5 years or at age of 60 or not backed up. When women do decide to have a trial cessation of HRT to see if it is still required for symptom control, either stopping suddenly or gradually makes no difference to whether or not symptoms will return. Explain to women with a uterus that unscheduled vaginal bleeding is common side effect of HRT within the first 3 months of treatment. Should be reported at the 3 months review appointment or promptly if it occurs after first 3 months. Follow up and referral. Discuss with the woman the importance of keeping up to date with nationally recommended health screening. Mammograph every 3 years, pap smear every 3 years. Review each treatment for short-term menopausal symptoms. The recommended follow-up schedule for HRT is 3 months, first 3 months, then 6 months, then yearly. What we do in the follow-up, we check the blood pressure, breast examination, vaginal examination, 3 yearly smear and 3 yearly mammography, age 50 to 64 years. The predict patient should be invited for an earlier visit for any specific problem. Review woman to a healthcare professional with expertise in menopause if treatment do not improve their menopausal symptoms or they have ongoing troublesome side effects. They have menopausal symptoms and contraindication to HRT, or there is uncertainty about the most suitable treatment options for their menopausal symptoms. Coming to premature ovarian insufficiency, the woman experiencing menopause under the age of 40 with menopausal symptoms and absent or infrequent periods should have diagnosis confirmed by two blood tests for FSH level taken 4 to 6 weeks apart. ये एग्जाम में क्वेश्चन आ सकता है in the OSCE, in the extended talks, or in the BCQs, or is it SAQs. So patient counseling, viva, किसी में भी आ सकता है. So woman who is under 40 years and having a menopausal symptoms or absent of frequent periods. Two blood tests is confirmed on two blood tests for FSH level taken 4 to 6 weeks apart. You have to counsel. This is the breaking bad news. एक young woman जो 40 साल से पहले की है और उसको मीनोपास हो रहा है, यू हैव, दिस इज़ द ब्रेकिंग बैड न्यूज़, सो यू फॉलो ऑल द स्टेप्स ऑफ ब्रेकिंग बैड न्यूज़. आफ्टर ब्रेकिंग द बैड न्यूज़ वो बोलेगी अब मेरा क्या होगा, मुझे क्या करना है, बच्चा होगा नहीं होगा, देन यू हैव टू एडवाइस हर, काउंसिलर, कि बच्चा भी नहीं होगा और हार्मोन्स भी देने पड़ेंगे. So hormone replacement in the form of HRT or the combined contraceptive pill should be offered and recommended to be continued at least until the average age of menopause, that is 51 years, unless there is a contraindication to the use of hormone replacement therapy. See, up to the average age of the menopause is required for bone and cardiovascular health as well as for symptoms control. Both HRT and combined contraceptive pill provided bone benefit, but HRT may have a better effect on the blood pressure. HRT should not be relied upon for contraception. So you have to counsel her first to break the bad news, and then counsel her in the layman language कि this is the ovary and ovary से अंडे निकलते हैं, उनसे ही हार्मोन्स निकलते हैं. अंडे is for the fertility, this ovum is for the fertility, and these hormones is necessary for the woman's health, their bone and their cardiovascular health, their bone health, their other health. So you have to counsel that. So once your ovaries are not producing eggs and hormones, so you may experience these symptoms. Your symptoms are because of these deficiency of the hormones. So then she asked what we do, what I will do now. तो फिर उसको बताना है कि छाती देनी है और इनफर्टिलिटी के लिए बेबी एडॉप्ट करना है. और even the gamete donation होती है, but gamete donation is not legal in the Pakistan or in the any Muslim countries. So 10 key messages for the menopause provide evidence-based information about menopause and treatment options that help women make informed individual decisions about menopause management. Do not use blood tests to diagnose the perimenopause or menopause in women over 45. Offer HRT first line for menopause related vasomotor symptoms and low mood. Do not routinely offer clonidine or antidepressant SSRI or SNRI. Do not use fluoxetine or paroxetine in women taking tamoxifen. There is a drug interaction, so tamoxifen effect may decrease. Offer long-term vaginal estrogen for urogenital symptoms even if she is taking the systemic HRT. Understand appropriate review and when to refer. Support women to choose when to stop HRT. Do not choose arbitrary limits. Use pictorial charts to discuss long-term risk and benefits of HRT. Do not use blood tests to confirm diagnosis of premature ovarian insufficiency and offer hormonal treatment up to average age of menopause at least. So do not use the blood test to confirm diagnosis of premature ovarian insufficiency in a woman who are taking the hormonal contraceptives. But if she is not taking hormonal contraceptive and she is under 40 years, you have to use the FSH at least 2 levels. Thank you.